everyone, Noor here, and welcome back to The Explainer. Today we are officially diving into part 2 of our MRCP Clinical Hematology and Oncology series. We've got a massive amount of dense, high-yield medical data to get through, but don't worry, we're going to explain each and everything. We literally will not miss a single crucial detail. We've structured this to be highly visual, so let's get you absolutely ready for those exams.
So here is our roadmap for today. We'll be covering anti-estrogen drugs, thrombophilia and coagulation, aplastic and autoimmune anemias, the beta thalassemia variants, and finally, a visual breakdown of pathological blood films. Let's just jump right in.
Section 1. Anti-estrogen oncology drugs. Okay, first up is tamoxifen. This is a selective estrogen receptor modulator, or SERM, which acts as both a partial agonist and an antagonist. But what's really crucial for you to remember here is the side effect profile. Look closely at the climacteric side effects, specifically hot flushes. Now, you might think, oh, that's pretty minor, right? Well, actually, a full 3% of patients literally stop taking tamoxifen entirely just because of these hot flushes. You also absolutely cannot forget the more severe adverse effects here: menstrual disturbances, an increased risk of a VTE, and the potential for endometrial cancer.
Moving on, we've got aromatase inhibitors, things like anastrozole and letrozole. Now, these work a bit differently. They reduce peripheral estrogen synthesis. This makes them your absolute go-to for ER-positive breast cancer in postmenopausal women. The adverse effects here are a little different too. They cause hot flushes, yeah, but also arthralgia, myalgia, and insomnia. But here is the major takeaway, the absolute must-know detail: osteoporosis. The risk is so significant that NICE guidelines actually mandate a DEXA scan when you start a patient on these. Seriously, do not forget that DEXA scan step.
All right, Section 2. Thrombophilia and coagulation disorders. Let's start with antiphospholipid syndrome, or APS. This is an acquired disorder that predisposes patients to venous and arterial thromboses, recurrent fetal loss, and thrombocytopenia. It can pop up on its own, or it's often secondary to conditions like SLE. Now, when a patient with APS gets pregnant, the stakes are, well, they're incredibly high. We're talking severe complications: recurrent miscarriage, intrauterine growth restriction, preeclampsia, placental abruption, and preterm delivery. Because those stakes are so high, the management protocol is incredibly strict. I really want you to lock this chronological timeline into your brain. Step 1. The absolute second a pregnancy is confirmed via a urine test, you start low-dose aspirin. Step 2. The moment you visualize a fetal heart on the ultrasound, you immediately add low molecular weight heparin, or LMWH. And then step 3, fast forward to 34 weeks gestation, and you discontinue that LMWH. It's a very specific life-saving protocol.
And why are we so obsessed with that specific sequence? 7. Implementing those exact interventions increases the live birth rate 7-fold. I mean, that is a massive, game-changing clinical impact.
Next up in coagulation is antithrombin 3 deficiency. This is an autosomal dominant inherited thrombophilia showing up in about 1 in 3,000 people. It normally inhibits thrombin, factor 10, and factor 9. These patients usually need lifelong warfarin. But here's the really tricky part, the catch. Antithrombin 3 is actually the very thing that mediates the effects of heparin. So these patients naturally have a degree of heparin resistance. If you absolutely have to use heparin, say during pregnancy, you have to aggressively monitor their anti-XA levels to make sure it's actually working. And this brilliantly illustrates the real so what here. Just look at the stark contrast between prevalence and the relative risk of a VTE. Factor V Leiden? Pretty common, right? About 5% prevalence, but only a 4 times relative risk. Prothrombin is at 1.5% with a 3 times risk. But as you scan down to protein C, protein S, and then you hit antithrombin 3 deficiency, the prevalence drops to a tiny 0.03%. But look at that VTE risk. It skyrockets to 10 to 20 times normal. Absolutely wild.
Moving right along to Section 3, aplastic and autoimmune anemias. So, managing aplastic anemia is really a multi-tiered approach. You always start with supportive care, blood products, infection control. Then you look at immunosuppression with things like cyclosporin or ATG and ALG. Now listen closely to this detail. ATG and ALG are prepared in animals, like rabbits or horses. Because of that, they are highly allergenic and can trigger severe serum sickness, fever, rash, arthralgia, the whole shebang. So you literally must provide steroid cover when you give them. And finally, if we're talking a definitive cure, an allogeneic stem cell transplant boasts up to an 80% success rate. Now let's look at autoimmune hemolytic anemia, or AIAH.
Before we even break down the types, you've got to know the general diagnostic picture. You're going to see anemia, obviously, plus reticulocytosis, low haptoglobin, and raised LDH and indirect bilirubin. Peek at the blood film, and you'll spot spherocytes and reticulocytes. But the absolute golden ticket for diagnosing AIAH, a positive direct antiglobulin test. You probably know it better as the Coombs test.
All right, so you've got a positive Coombs test. Now what? Well, you have to figure out if it's warm or cold AIH. Let's put them side by side. Warm is your most common type. It's driven by IgG antibodies, works best at body temperature, happens extravascularly, usually in the spleen, and you treat it with steroids or rituximab. Cold AIH is a whole different beast. That's driven by IgM antibodies at around 4 degrees Celsius. It's an intravascular process, and patients often show up with Raynaud's. And unlike warm AIH, it has a famously poor response to steroids.
Section 4. Beta thalassemia variants.
Let's see how this builds into genetic disorders. We have to juxtapose the beta thalassemia major against the trait variant. With major, there is a total absence of beta globulin chains. It shows up in the very first year of life with failure to thrive. HbA is completely absent. These poor kids need repeated transfusions, which then tragically leads to iron overload, meaning you absolutely have to use iron chelation therapy, like desferrioxamine. Now, contrast that with beta thalassemia trait. This is generally completely asymptomatic. You'll see a mild hypochromic microcytic anemia. But the key diagnostic marker here, a raised HbA2 above 3.5%.
And finally, Section 5, pathological blood films. This is where things get highly visual. We're going down to the microscope level. Memorizing these associations is basically free points on an exam. If you see target cells, think sickle cell, thalassemia, or iron deficiency. Teardrop cells, that immediately points you toward myelofibrosis. Spherocytes scream AIH. Basophilic stippling is your classic red flag for lead poisoning. Howell-Jolly bodies indicate hyposplenism. And Heinz bodies are heavily associated with G6PD deficiency.
Let's keep going. Schistocytes, or helmet cells, mean mechanical destruction. Think DIC or a mechanical heart valve. Pencil cells are a dead giveaway for iron deficiency anemia. Burr cells, also known as echinocytes, have a super strong link to uremia. Acanthocytes signal abeta-lipoproteinemia. And my personal favorite, if you spot hypersegmented neutrophils, your brain should immediately lock on to megaloblastic anemia. No question. Now let's take all those isolated clues and put them together into classic clinical pictures. For hyposplenism, which by the way shows up in about 30% of celiac patients, you're going to see a massive cluster of markers. Target cells, Howell-Jolly bodies, Pappenheimer bodies, cytotic granules, the works. For a classic iron deficiency picture, you want target cells and pencil cells. But here's a really great diagnostic nuance. If that iron deficiency is mixed with a B12 or folate deficiency, you get a dim morphic film, basically a mix of both microcytic and macrocytic cells right there on the same slide.
Let's wrap up these clinical pictures with 3 incredibly stark signs. Myelofibrosis, teardrop cells, intravascular hemolysis, schistocytes, megaloblastic anemia, hypersegmented neutrophils. Tying these specific morphological shapes directly to the overarching condition is exactly how you're going to synthesize this material for the wards.
We have covered a massive amount of ground today, from that 3% dropout rate with tamoxifen to the strict 3-step LMWH protocol in APS, all the way to spotting a pencil cell under the microscope. So with dozens of morphological clues and dense pharmacological protocols now sitting right there in your arsenal, which single detail will be the key to unlocking your very next clinical diagnosis? Take some time, review these concepts, and really trust the structure we built today. Thank you so much for joining me for this explainer. See you next time.